Another misconception is if your thyroid's off and you're having trouble losing weight, once you start thyroid hormone replacement, you're going to magically lose weight. Well, that's not the case either. Thyroid is affected by so many things. Insulin resistance in and of itself is affected by so many things. I try and manage expectations with patients that, yes, we want to get your thyroid in balance, but let's look at everything else that's influencing your weight too.
So the context for this episode is that it's part of a series we're doing around systems of the body and really trying to hone in on a couple of things. How do we measure the health of that system? How does it relate to the rest of the body? And then what can we do to keep it healthy? What can we do to make sure that, if we do have a result or something that's out of line, that we can bring it back in or just not get an out of range, result for that health.
Right.
So today we're focusing on thyroid.
Okay.
So maybe as a place to start, just tell me a little bit about your background. How did you come to focus on the thyroid?
Sure. I didn't start out like just focusing on thyroid. I really went into endocrinology because diabetes runs in my family. So endocrinology really is the study of all things hormones, all those countless chemical neurotransmitters that make everything happen in our body. So not just insulin, like with type 2 or type 1 diabetes, but also thyroid, also our sex steroids like estrogen, progesterone, testosterone. Cortisol's a big one, our stress hormone. But when I got out of training, the practice I joined, I was the only person that did thyroid ultrasounds and thyroid biopsies. So I naturally got a lot of the thyroid patients. And what I found was, one, we were missing a lot of patients with thyroid issues. We weren't treating them correctly. Patients were dissatisfied. That's when I started looking at other things like lifestyle, micronutrients, gut health. That brought me to integrative medicine. And integrative medicine really kind of takes the best of traditional medicine and functional medicine. And that's when I started Metabolic Center for Wellness. And this summer will be our 10-year anniversary. So that's where we take care of persons with all types of hormone issues. A lot of them are thyroid, but thyroid overlaps with a lot of other hormone issues because thyroid doesn't just exist in a vacuum. So we take care of hyperthyroidism, which is overactive thyroid, hypothyroidism, underactive, thyroid nodules, thyroid cancer. And but basically we look at the whole person. I try and work with my patients to figure out how can we get you feeling your best now and years down the line. That's what the end goal is. Focusing on resilience and longevity.
Well, that's a really good place, I think, to get into what the thyroid actually does, because you mentioned it does a lot of things. And I feel like it's one of those organs everybody's heard of, and probably nobody really knows what it does until you have a problem, and then you have to learn quickly. So tell me about what the thyroid's doing in our body.
So the thyroid is a pretty important gland because it makes thyroid hormone. So thyroid hormone is our hormone of metabolism. So a lot of people think, all right, what is metabolism? That's the actual question. We think, all right, well, it's what we take in as food and drink, and we make energy from it, which it is. That's what the metabolism is. But it's really a lot more than that. Metabolism is all the countless enzyme reactions that are going on in our body at every single point in time. Every single cell of our being is influenced by thyroid hormone. So that's why it's so very important. And, if we don't have our thyroid in balance, whether it's too much or too little, it can make us feel horrible, but it can also lead to complications down the line, especially from cardiometabolic standpoint, bone standpoint, brain standpoint, and countless other reasons why. So that's why the thyroid's important, but then we can always dig into exactly the specifics on it. But
yeah, it's a bit of it's kind of what the right analogy is, but it sort of drives the rest of the hormones, right? Like, as I understand it, the thyroid hormones are essentially signaling to the rest of the body of how to control some of the other hormone levels.
Exactly.
Is that fair?
We sometimes call it the thermostat
Sure.
of our body. Yeah.
That's a really good one. Okay. So if we start to see dysfunction in that, it's sort of upstream of then some other dysfunction that might manifest with other systems being off.
Exactly. And the thyroid itself can be influenced by so many other things too that's going on in our body that we don't even think about. So the thyroid's a pretty sensitive little gland. It's super important, but it's important for what it does, which is making thyroid hormone, but it's influenced by so many things.
My background's in nutrition. I thought I knew everything, but it wasn't till I was tracking that I had to ground truth my assumptions with what was actually happening in my real life. The only way to actually know what works is real data. Using levels has been life-changing. For one, I've learned how food individually affects me. Even though I know as a physician how stress impacts your glucose levels and your cortisol levels, it was very eye-opening to see right in front of me in real data that my glucose levels go through the roof under certain forms of stress. You can see how food, stress, sleep, and exercise impact you personally to make smarter choices that improve your health. With features like AI-powered food logging, real-time blood sugar tracking, comprehensive blood testing, and personalized dietitian support, Levels gives you everything you need to optimize your health. Whether your goal is losing weight, having more energy, or choosing the right diet for you, Levels gives you the full picture of your metabolic health. Stop guessing, start knowing, check out Levels, and click the first link in the description. Now, back to the episode.
So let's talk about what dysfunction looks like. You mentioned hyper and hypo. I think those are the two things people are, maybe most familiar with. So hypo being not enough thyroid hormone, hyper being too much. Let's maybe just start with hyper. What does that look like? How does that manifest in the body? And then what do we do about it if somebody's got hyperthyroidism?
Great question. So hyperthyroidism, sometimes you'll hear the term thyrotoxicosis. In the States here, the most common cause of, and probably across the world, the most common cause of hyperthyroidism is Graves' disease, which we can always talk about autoimmune thyroid issues because that's what it is. But what do people feel? Well, think of that hypermetabolic state. So folks usually feel sometimes anxious, trouble sleeping. Some people may feel fatigued, heart racing. They can have gut issues like loose stools. They can feel shaky. It's not a good feeling at all. Some people, we tend to think, okay, if you're hyperthyroid, you're going to lose weight. Not the case, because a lot of people actually gain weight when they're hyperthyroid. They may lose muscle, but it's a stressful state. That gets us into the effects of cortisol. Cortisol is our stress hormone, and cortisol increases our insulin resistance, so we hold on to all the stores that we have because it's survival mode. So folks with overactive thyroid sometimes experience weight gain.
Oh, that's interesting. Right. Yeah, I could imagine, right, if you think like, oh, this is ramping up my metabolism, and we all sort of have this picture of fast metabolism eques skinny.
Right.
It's a great point that the cascade, to what we were talking about, the impact that it has down the line. So too much thyroid hormone is going to make cortisol production.
Exactly.
And then the cortisol is going to drive that insulin resistance. That insulin resistance is going to make that glucose stay in the system. It's going to make the fat not get burned. And you're going to ultimately end up with potentially weight gain.
Right. And I'll have folks who have hypothyroidism are like, oh, I wish I had hyperthyroidism. No, that's not the case. It can be a very kind of disturbing way of living. I mean, people tend to present for evaluation for hyperthyroidism before they present for underactive thyroid because it tends to be very alarming. And folks with hyperthyroidism also may have swelling in their neck, but that we call that a thyromegaly that can go along with hyperthyroidism, and eye issues. You might see a lot of the commercials on television for thyroid eye disease. That's a very specific type of inflammation within the tissues behind the eyes that cause almost that stare, or some people call it some bulging. But that can all go along with hyperthyroidism.
I've read about the eye disease component of this, but I don't really understand the mechanistic relationship. Yeah. I sort of get that other hormone cascade we were talking about, but how does hyperthyroidism end up affecting the eyes?
So there's really two ways hyperthyroidism can affect the eyes. So there's the sympathetic overdrive that can cause what we call eyelid retraction. That goes away very quickly once we bring folks to what we call a euthyroid state or normal thyroid state. But there's another autoimmune component that's going on that, despite bringing thyroid levels back in normal, can keep happening. So it's an autoimmune reaction that causes inflammation in the tissues behind the eyes, and it can be very progressive. It can be anything from just dry eyes or itchy eyes to it can cause double vision. It really can impact a person's life where they can't drive, they're bumping into things, and in very severe cases, it can cause blindness. So that's more of an autoimmune component where it doesn't respond to just bringing a person to a euthyroid state.
Okay. You mentioned Graves' disease being the most common cause of hyperthyroidism. That is an autoimmune condition. Mm-hmm. What do we know about the pathogenesis of this? Why do some people develop Graves and other people don't?
That's a great question. So when we think about autoimmune diseases in general, I always refer to what's called the autoimmune triangle. So there's 3 points of the triangle. There's genetic predisposition. So, I mean, we're born with genes. Some of them get turned on, some of them get turned off. But the ones that get turned on are the problems, especially when it comes to autoimmune thyroid disease. The second part of the triangle is things we're exposed to over time, whether it's stress, whether it's environmental toxins, whether it's viruses, medicines we're put on. That kind of is something that we're exposed to along our biography of our thyroid life. And then there's finally the point of even our gut actually plays that third point of the triangle. So those 2 points of the triangle may be enough to set someone into autoimmune thyroid disease, but I always try to encourage my patients to say, we can't control the past, but if we can focus on the gut is something that's very much in our control, and we can work to bring it into normal range. Not that it's going to get rid of things sometimes, but it is really a multifactorial process that we develop autoimmune thyroid issues.
And what does treatment look like if I come to you and we diagnose hyperthyroidism and we do recognize it's an autoimmune driver of it? How do we manage it?
Great question. So, and I teach other physicians on managing the initial parts of Graves' disease. And I always encourage primary care physicians to really partner with an endocrinologist and someone who's been recently diagnosed with Graves' disease, because it can escalate very quickly. So the initial evaluations, once we've confirmed it's Graves' disease, what we usually start is something for symptomatic relief. So like that heart racing, that anxiety, usually that's going to be a beta blocker, which is a medicine that's usually used for high blood pressure, but it really helps calm down the sympathetic overdrive. It'll help people sleep better, help feel more relaxed. Then we kind of take it from there. There's three routes you can go at this point. So there's medicine. So there's medicine that blocks thyroid hormone production and blocks, we call the conversion to active thyroid hormone in the system. There's surgery, and then there's radioactive iodine. Me as a physician, I try and put surgery and radioactive iodine. So radioactive iodine is treating someone with a dose of iodine that's radioactive. So essentially the thyroid takes up the iodine. In some cases, it shuts down the thyroid function permanently. Sometimes it needs to be treated again. Sometimes it doesn't work. But surgery and radioactive iodine are things that we can't take back. Right. So once they're there, they're there. So I usually start with the medicine along with symptomatic relief. And as an integrative doctor, I always start our functional treatments. So working on stress management, working on gut health. And we have great antioxidants that really help kind of cool off the thyroid. So in my experience with Graves' disease, and it's been 15 years now, I'm very successful in getting patients off of anti-thyroid medicines with our integrative therapies. I can tell you in 15 years, I've maybe referred 2 people for surgery and none for radioactive iodine.
So you do see a pretty good effect size just from managing the lifestyle interventions.
Yes. And since it is autoimmune, sometimes these patients can also have antibodies that go along with Graves, but also Hashimoto thyroiditis, which is the underactive form. So we kind of have to monitor both.
Oh, interesting. Well, yeah, let's transition into hypo, because you mentioned Hashimoto's. What does it look like when I don't have enough thyroid hormone?
It can be gradual in onset. These are more like kind of symptoms that sneak up on us. It can be fatigue over time. It can be a little bit of brain fog, a little bit of mood changes, some gut issues like constipation, joint pains. For women, menstrual irregularities, or if they're trying to get pregnant, may have trouble getting pregnant. But you may also see things on the labs like cholesterol issues when you never had cholesterol issues before. So it can be very subtle. I'll tell you, one of the things that will drive people to get evaluated for thyroid, especially women, is if they're having hair changes. So hair loss is a big sign of hypothyroidism and dry skin. And when you start to see something from the external environment, then you're like, you know what, I better get this checked out.
Interesting. So those all sound like symptoms that could have lots of different causes.
So
I'm thinking
many.
of
Yes, that's
other
the tough
conversations
thing.
I've had with people talking about other systems of the body, and I recognize some of those symptoms as well. That could be an indication of this. So
There's so much overlap.
how do you end up diagnosing it? What do you do when somebody comes to you with some of those sort of nondescript symptoms? How do you decide, yes, this is in fact hypothyroidism?
Right. So I always take a good clinical symptomatology log, which hopefully most physicians do. Then I start with the lab testing. So we get the basic labs. TSH, which we can talk about, is a screening test. But, I always look at the circulating thyroid levels, which are T4 and T3. I check for thyroid antibodies. So I'm looking for, is there an autoimmune thyroid issue that we're missing that may, even though the screening test may be normal, is my patient actually having symptoms that go along with this progression of Hashimoto thyroiditis? That's kind of where I start for screening. I tend to check micronutrients as well. If I'm thinking thyroid, I check for iodine. I check for iron, especially in women. Women, we tend to be low in iron, and our thyroid is very reliant upon iron. So if we're not getting enough iron, the thyroid's just not going to work right. So the thyroid is very reliant upon micronutrients. And I do also have the luxury of an ultrasound. So if I'm really thinking something like a Hashimoto thyroiditis, I do ultrasounds very regularly.
Yeah, let's maybe unpack those hormones a little bit in those tests, because it does relate to the actual sort of diagnostics of this. So yeah, maybe tell me more about TSH. What is thyroid stimulating hormone doing?
Great. So TSH is really an indirect measure of thyroid function. So we have to kind of go back to how is thyroid hormone regulated. So there are very specific parts of our brain, hypothalamus and the pituitary, which are constantly sensing what our body's needs are in terms of hormones. When it comes to thyroid, they're sensing circulating thyroid levels. So if our brain essentially is sensing that we're not making enough thyroid hormone, TSH should go up to say, hey, thyroid, you need to make more thyroid hormone. Our body needs more thyroid hormone. The same would be true if the brain was sensing we're making too much thyroid hormone. Then the TSH should go down. Now, once TSH goes up, if that's the case, then our thyroid should start kind of getting all the machinery together to start making thyroid hormone. And that's got many steps involved in that too. But TSH itself is just an indirect measure of thyroid function. It has a wide range. If you're looking at your labs, if you're at home looking at your labs, there's a range between 0.4 and 4.5. The debate is, what's normal? As an integrative endocrinologist, I try and shoot for a person's optimal thyroid TSH range, which probably is right around 1 or 2. But what we're finding in genomic studies is there's going to be patients that their optimal TSH may be a little bit higher and their optimal TSH may be a little lower. And when we're looking at longevity studies, that perhaps TSHs should be a little bit higher. When we look at centenarians and supercentenarians, that their TSHs tend to be a little higher. So it's a work in progress on the TSH. But again, the take-home point is it's just really a screening test.
Okay, so I get my TSH and that tells me something. Then
Yes.
what's the relationship I would expect to see then if I get, maybe first explain what a complete thyroid panel is, what else then you're testing, and then what should I see in those markers, or what's the
Sure.
relationship between a TSH reading and the other markers?
Ideally, say your TSH is outside of the normal range on the high range. If we check your circulating levels, so free T4 and free T3. Now, I will mention free T4, or T4 is what the thyroid makes mainly. T4 gets released into the body and it gets converted to T3 or free T3. That's really what does the work of the thyroid. T4 is a prohormone. It has to be converted to T3. So T3 is what interacts at the level of the cell that targets the receptors on the respective cell and does the work. That's the workhorse, if you will. So if your TSH is on the high end, ideally we should see a lower or low normal T3 and T4. So meaning that your brain is sensing not enough. When that TSH is high, it means that those levels are low.
Okay, so that tells us the system's working basically as
Right.
it's supposed to.
In an ideal world.
So if we get a high TSH reading and then we see high markers, high T3 or T4.
Now that's going to mean something's going on at the level of the brain.
Okay.
So that's pretty rare.
Got it.
That would be more like a TSH secreting tumor of the pituitary. Very rare. So that's usually not a circumstance that we see. There can be low, like There's also rare cases of thyroid hormone resistance where TSH may be a little bit high, and circulating levels may be in a weird range where it doesn't make sense. That's not the normal situation.
Okay.
Yeah.
And I know some of the debate out there around thyroid is, well, I have normal TSH levels, but maybe something's still wrong.
Right.
Is that a case we run into? Do we get normal TSH levels, but we still have some symptoms that suggest something to you, so then you go look at T3 and T4 and find things are abnormal?
That's exactly the case. So oftentimes, since I'm sometimes someone's second or third opinion when it comes to thyroid, people will say, well, my TSH is normal, but I don't feel normal. So that's where we kind of dig in a little bit more with the circulating levels. I check for the antibodies because the TSH we'll catch it and it looks normal. But if you have an underlying evolving Hashimoto thyroiditis, because that's a progressive thing, patients may have symptoms. So those antibodies give me a lot of information. And then there's another factor in there called reverse T3. So as I mentioned, T4 gets converted to T3 to be Fc active, but can also convert T4 to reverse T3. So reverse T3 is the inactive form of T3. It looks so similar to free T3 that it can actually block the receptor, so free T3 can't get to the cell and do what it needs. And we see cases of elevated reverse T3 where that's a sign of something else going on. So that's where we have to dig in, because that means the body is converting to an inactive form for some reason. And that usually points to something going on at the level of the mitochondria, which are the powerhouse of the cell. So that's a red flag to me. So.
Got it. You brought up reverse T3. It's one of those phrases I see sort of kicked around, both as a legit marker and as a don't pay attention to this because it's not sort of real, or can be sort of misinterpreted. Why is there some debate around the role of reverse T3?
Well, when I was in training, I was told the only time to check reverse T3 is someone who's super sick in the hospital, because it could be an evolving, we'll call it a euthyroid sick, which we kind of have fallen out of use of that term. But it's tough to change mindsets when it comes to medicine in general, because we're used, even as doctors, we're trained a certain way, and it's tough to change the way you're thinking. But we have more and more proof that reverse T3 is legitimate. It gives us a lot of information, especially even if, say, someone's on thyroid hormone replacement, and we can talk about that, but the standard of care is levothyroxine, which is T4. So if someone's on too much T4, we're going to start making too much reverse T3. And that's kind of counterproductive as well. So reverse T3 is a very valid marker, because it not only clues us in to what's going on at the level of the cell, but also if you're on treatment, are we mistreating someone with too much T4?
Interesting. So there is clinical utility,
of course,
to looking at those markers.
Yeah, I try and check it in anyone who's on thyroid hormone replacement too.
Okay. So would that be part of we mentioned complete thyroid panel, so I assume that would include T3, T4, cortisol, antibodies. What all is going to be checked if I go to an endocrinologist to get a complete thyroid panel?
Yeah, ideally we should be checking those markers. You bring up cortisol, which is so important, because cortisol is it's our stress hormone. It's really our most important hormone. We need this hormone to live. And cortisol and thyroid go hand in hand. So it's essential to know what's going on at the level of the hypothalamic pituitary adrenal axis, as well as the HPT axis. So if we miss something going on with the adrenals, it's next to impossible to treat the thyroid correctly. It just won't work. In addition to the thyroid antibodies, so thyroid antibodies are the thyroglobulin antibodies. So thyroglobulin is really the substance of the thyroid, and when we see antibodies against that, it means that our immune system is working against our thyroid.
Right.
And then there's anti-TPO, which is anti-thyroid peroxidase antibody. Thyroid peroxidase is really that super important enzyme that's within our thyroid that makes thyroid hormone. That's what iron is really important for. If we don't have enough iron, that enzyme can't work, but we shouldn't see antibodies to that in our system. And I think that was we said the reverse T3. And I do check micronutrients, because lots of times if I have someone who's just slightly thyroid levels are off, we check the micronutrients like iodine, selenium, super important. As I mentioned, iron, magnesium, zinc. we replace the micronutrients, then the thyroid has what it needs to work, and we don't need to put someone on thyroid hormone replacement.
Got it. So what kind of, we talked about some of these other markers. If I'm looking at sort of blood labs that I get back and my TSH is normal, or even if it's not, I guess the question is, are there combinations of markers that would reveal something to you? Or if my TSH normals or TSH levels are normal, but I'm feeling off, I'm having some symptoms that are consistent with potentially a thyroid issue, I should just sort of go see an endocrinologist and let them dive further? Or are there really telling patterns that would emerge among the set of markers we're talking about?
Yeah, I mean, if things are if we see a high TSH, low T4, T3, then definitely there's something going on. If you see some like a normal TSH and some like a little bit low T4, T3, but there's thyroid antibodies, then that's something to get checked out as well. Okay. On the other hand of the spectrum, if TSH is low and we see high T3, maybe high normal T4, that has to be checked out too, because that goes along with the hyperthyroidism. And then there's subtle things, and you mentioned there's a lot of overlap with other systems. So, I mean, that's why it's important to make sure, one, you get a thorough evaluation, even if you suspect you have thyroid issues, as well as make sure you're not missing anything else.
How durable are thyroid markers? Meaning, if I get it tested today versus next week, how much variation should I expect to see?
That's a great question. And it's going to depend. If you're kind of in your normal stable state and no medicines have been changed or anything, T4 has a half-life of about a week. So just kind of, so that means it hangs around in your system for a week. So, I mean, that really shouldn't change too much. T3, which is our active thyroid hormone, has a half-life of about a day. So that can change fairly regularly based upon the point in time that we're checking. Now, TSH does change a little more slowly. I usually, if say I have someone on thyroid hormone replacement, I wait at least 6 to 8 weeks to recheck them again, because we want a good steady state with that.
Okay. But if I know with a lot of markers, doctors will often say, if I get an abnormal result, my first thing I do is just retest, because it might just be off because it's off for whatever reason. It sounds like the thyroid hormones are going to be a little bit more telling even in that initial reading.
Yes. I mean, if you just don't trust the assay, that's one thing to recheck. I mean, there's no harm in rechecking, but if something's abnormal, I wouldn't say, all right, let's check it again in a year. I mean, that's not something that I would put off for that long.
Right. And you mentioned ultrasound and imaging. When does that come into the picture, and what are you learning by imaging the thyroid?
Oh, yeah. Ultrasound is really the best way from an imaging standpoint of looking at the thyroid. I mean, it's like a real time, no radiation. I mean, I see a lot of patients, as far as new patients, for thyroid nodule biopsies and thyroid nodule ablations. So ablations are a way of non-surgically shrinking thyroid nodules. But so ultrasound serves the purpose of, one, identifying if there's a nodule. So nodules are like masses within the thyroid. Most of them are benign, but depending upon the characteristics of the nodule, we think as far as, let's rule this out for cancer. Even though less than 10% of the nodules we biopsy are cancerous, we don't want to miss thyroid cancer. But thyroid ultrasound can also give an idea of what's going on at the level of the function of the thyroid, specifically in autoimmune thyroid issues. So say, for example, I have someone who comes in that I suspect Graves' disease, but I only have like a low TSH and maybe a weird T3. I'll say, let's not even wait for labs, just do an ultrasound right now. I'll know what's going on and help me figure out, is it something that's temporary or is it Graves' disease? Because I just put the ultrasound down, I can see changes that go along with Graves' disease. So we'll see this fibrotic changes sometimes, a lot of vasculature. Now, on the other hand, if I want to say, hey, I think this is Hashimoto thyroiditis, I can see changes on the ultrasound with that. But what that will also tell me is, in an ideal situation, when I look under the ultrasound, it should be this nice ground glass kind of look of the thyroid. But if I start seeing changes that look like more permanent changes, it'll give me an idea, all right, are we going to be able to treat this? Are we able to, one, be able to get persons off of thyroid hormone replacement and heal the thyroid, or is this something that's a little bit more progressed?
Interesting. So even in the kind of hyper and nodules, I understand, and we'll come back and talk more about that, but even in the hyper and conditions, you're actually seeing a physical change to
Yeah.
is it to the sort of texture or shape of it? Does it get bigger or smaller? What are you actually seeing?
Yeah, that's a great question because it kind of depends upon the point in time where we kind of catch the issue going on. Sometimes we'll just see these, especially in Hashimoto thyroiditis, because it's kind of an ongoing autoimmune. The immune system's kind of just chipping away at the thyroid itself, and that's why it's not working correctly, because the thyroid's made up of follicles that are constantly making thyroid hormone, and when we are attacking these follicles, we start seeing little patches within the. So that's kind of more early on, I would have to say, and it can be, the thyroid itself can be enlarged at first because of this inflammation, because thyroiditis is an inflammation. Anything itis is an inflammation. And over time, if it's sort of someone who's had Hashimoto thyroiditis for 30 years, we start to see shrinking of the thyroid itself. And it can actually be very, very little thyroid tissue left.
Right. Interesting. So coming back to nodules, my understanding is they're very common.
Super common.
That maybe as much as 50, 60% of adults have some nodules
Yes.
on their thyroid. What is the nodule doing? Why do we have a nodule? Like, what is it made of?
That's a great question. Well, I always tell my patients, if we ultrasound everybody that walks down the street, about 1 in 3 persons is going to show up with some sort of thyroid abnormality on their ultrasound sometime in their life. Now, the question there's different types of nodules. So some nodules are mainly liquid, they're cystic. Those are usually never a problem. They can be more of a problem if they continue to fill up with cyst fluid, and we have to drain them or do a procedure to ablate them down so they stop filling up. Some are more solid with a little bit of liquid, and some are mainly solid. The question is, what causes these thyroid nodules to be there in the first place? And we used to think it was abnormalities as far as iodine. So too much or too little iodine, it can cause thyroid nodules. But what we're finding now is the thyroid, since it is influenced by so many things, inflammation is more likely the cause of these nodules. And unfortunately, by the time we know there's a nodule there, perhaps that inflammation isn't there anymore. So even with COVID, my patients that I were following with thyroid nodules, we saw an increase in growth of the nodule after they had infection. So, I mean, it's kind of a work in progress on that, because it's tough. You don't know that point in time that triggered the nodule to start growing. But we do know that as far as cancer, I mean, that's in and of itself, inflammation does impact thyroid cancer as well.
Right. So if I've come to you for some kind of a suspected thyroid issue, we've done the imaging and we see nodules, what's the next step?
Depending upon the nodule itself, so there's certain criteria when we look at nodules to determine do we want to do a biopsy? It's based off of size, how it looks under the ultrasound, its vascularity, if it has what we call microcalcifications, which are little spots of calcium. Then I discuss with the patient, all right, well, we need to do a biopsy just to make sure this isn't cancer, even though, as I mentioned, less than 10% of the nodules we biopsy are cancer. That's kind of the next case. If we don't biopsy, and this is the first time I'm looking at it, I usually say, all right, let's take a look at it again in 4 to 6 months just to make sure nothing's changed that I can see, because the ultrasound report that we get, that's a whole nother ballgame. They're not accurate a lot of the time. So, and it's not consistent. So I like to be able to monitor consistently. So whether we biopsy or we observe, and then there's nodules that just really bother people. I mean, if they're large nodules, it's on their neck, they can see it. Then we talk about what are ways that we can shrink this nodule for you so it doesn't bother you as much. Because sometimes nodules, they're not only cosmetically bothersome, they can press on your windpipe, they can cause you shortness of breath, they can cause you trouble swallowing, they can press on the nerve that goes to your vocal cords and cause hoarseness. So, I mean, nodules, even benign nodules can be a problem.
Right. So the detection of nodules isn't in and of itself something to freak out or worry about.
Exactly, yeah.
But then and even if you find a nodule, even if you do a biopsy, is thyroid cancer one of those cancers like a prostate that could be very slow growing, that you may not even intervene right away, even if the biopsy suggests this might be cancerous?
Yes, 100% yes. So there's 4 varieties of thyroid cancer. The most common variety is papillary thyroid cancer that grows very, very, very slowly. So say we have a small, we call it a microcarcinoma. So that would be like less than a centimeter. That's papillary. Even according to the American Thyroid Association, we have options. So it can be, yes, remove half of the thyroid lobe. So that would be go to surgery. And that would leave a person with the other half of their thyroid, and hopefully that part of the thyroid works well. We have the option of observation. So that in and of itself causes a little bit of unease with people. So it's saying, well, we know you have cancer. We're just going to look at it every 6 months to a year. And that can be a very uneasy feeling for a person. I don't know that I would like that.
Yeah.
But now we have radiofrequency ablation, which is RFA, which is a non-surgical treatment. So depending upon that size of that, or where that micropapillary carcinoma is, we can actually ablate it. And that's an active thing we can do to get rid of it.
Right.
So we have options. Now, more aggressive cancers, then it depends.
Right. Yeah, talk more about ablation. That's one of your specialties, as I understand. What does that look like? What does it look like what's the feeling? What process do I go through if I'm having something ablated?
Right. So there's great question. There's a couple different types of ablation. For those cystic nodules that I mentioned, there's something called PEI, or percutaneous ethanol injection. Basically, what that is we take out all the cyst fluid, put it in a little dehydrated alcohol that fibroses the inside of the nodule so it doesn't fill up again, and you're good to go. Now, radiofrequency ablation, that's better for more complex or heterogeneous or solid nodules. So basically, depending upon where that nodule is in the thyroid, RFA is a great treatment that patients themselves are really pushing for this, that we're trying to educate physicians more, because we're stuck in that same mindset. If you have a nodule, the only treatment is, if you're going to do something, is surgery. So depending upon the patient, RFA is we do it right in the office. Basically, it takes about 45 minutes. You're numb the whole time. We do keep people awake because we want to monitor their voice, because that's something, we want to make sure we're not causing any irritation to the vocal cords or the nerve that goes to the vocal cords. But basically, the goal is at 6 months to see a 70% reduction in the thyroid nodule. And it saves people from going for surgery, because if someone goes for thyroid surgery, we really haven't treated the nodule. We've just removed the whole thyroid. We have a whole nother problem. And recreating what a gland does on its own is a lot more complicated than it is. Because it changes essentially the trajectory of your life from that point on, just to get rid of a nodule. So that's kind of the benefit of the RFA.
So if we do end up in that surgery route and we lose part, or I understand you could also remove the entire thyroid,
yes.
Right? Yeah. What do I do then? What does it look like if I don't have my thyroid?
Right. And that's a challenge that we come up with. And I care for a lot of persons that don't have their thyroids anymore, whether it's for thyroid cancer or they had thyroid nodules. It's tough because it's not a one size fits all. So the standard of care is levothyroxine, which is T4. Now T4 has to be converted to T3 to be active, which we talked about. There's about 15% of the population that doesn't, they have what we call genetic polymorphisms, or gene mutations, where that enzyme is called deiodinase 2. They don't make that. So they can't convert T4 to T3. Whatever they were getting was because of other enzymes that were converting. So that specific enzyme is important for our brain, because we're not going to be able to convert T4 to T3. These are the persons that are not going to do well on just levothyroxine. And again, we're trying to bring more notoriety about that there's 15% of the population that you take their thyroids out, they're going to end up with high blood pressure, they're going to gain weight, they're going to develop mood disorders, just because they've had their thyroid taken out and they're just on T4. And that's where the personalization of thyroid hormone replacement is important.
And that leads to what I've seen referred to as combination therapy, right? Where
Yes.
you're doing T3 and T4 together.
Mm-hmm.
And is that only have utility in those cases, in those 15% of people who don't? Or are there other cases in which we're finding, because I understand this is relatively new, the idea of combination therapy, and still maybe a little bit debated. What's the utility of combination therapy?
Actually, it's beneficial for a lot of people. And if you think about it, kind of we go back to the first thyroid hormone replacement we ever had, it's something called desiccated thyroid extract. So that came from, the original one was bovine thyroid extract. So back in the 1890s, Dr. Murray actually he treated someone with what we call thyroid myxedema coma. So that's a very severe form of hypothyroidism with this thyroid extract. So up until, and that's thyroid itself. So it's got all the parts of the thyroid. It's got T4 and T3. So that actually was the original combination therapy. And then fast forward, the development of the TSH assay, as well as levothyroxine. At that point, the tide shifted to shifting everybody over to levothyroxine, following mainly just the TSH. That's where we started having the emergence of patients with persistent hypothyroid symptoms and people that just weren't getting better on T4. Now the pendulum's swinging back again, where looking at our complete thyroid panel, some people need that extra T3, whether it's in the form of levothyroxine plus liothyronine, which is T3 together, or a desiccated thyroid extract like would be like Armour Thyroid or NP Thyroid. Those are kind of the brand names. But
okay. So it sounds like, particularly when we get to even at the diagnostic stage, but particularly at the treatment stage, it sounds like there's a lot of individuality that comes into play here. And that's just due to our bodies being different, or is it interacting with other systems? In other words, if I have something else off in me, if I have type 2 diabetes and I have a thyroid issue, does that point you in a different treatment direction?
Yes, it's actually, I think, the most personalized medicine there is when it comes to thyroid hormone replacement. But you are correct. It's going to be influenced by our other systems like our adrenal status, inflammation in general. Women, perimenopause and menopause is a huge one because changes that happen with our estrogen and progesterone as we age, and perimenopause starts in a woman's early 40s. For some people, it's late 30s. And it's all the way through menopause, which is just a point in time. But that at least 10-year block it's changing thyroid function too. And it's affecting if a woman's on thyroid hormone replacement or if she's evolving into having a Hashimoto thyroiditis. That's one thing that we see a lot of.
One of the areas I want to make sure we have time to cover here is misinformation, or maybe confusion, to be sort of less malign about it. But thyroid is one of those things that gets talked about a lot more than I think other organs, on social media, among influencers, among maybe folks who aren't qualified, or just people, who have good faith debate about some of these diagnostic criteria, some of these treatment sort of plans. Maybe I'll just start here. What is some of the most persistent things you see out there that folks come to you with that they've heard or they've read somewhere or somebody's told them that you have to kind of correct or knock down? What are some of the most common myths or misunderstandings about thyroid health?
One that I've seen is if you're on thyroid hormone replacement, it kind of dates back to just following temperature. So that we advance thyroid hormone replacement until temperatures normalize. That actually has fallen to the side. That's what at one point was called Wilson's temperature syndrome. Because what that ended up doing was making people hyperthyroid. And I had one patient who was doing that on their own and ended up in the ER. So it's not a good route to go. I mean, we want to use clinical along with the labs because that's what we have them for. Another misconception is if your thyroid's off and you're having trouble losing weight, once you start thyroid hormone replacement, you're going to magically lose weight. Well, that's not the case either. Again, thyroid is affected by so many things. Insulin resistance in and of itself is affected by so many things. So I try and manage expectations with patients that, yes, we want to get your thyroid in balance, but let's look at everything else that's influencing your weight too. Because it's just putting someone on thyroid hormone replacement, you're not going to lose like 20 pounds overnight. That's kind of the big one. And managing expectations is probably a big one because there's just no overnight change. I mean, even when thyroid hormone is perfect, we still have to continue to address the other factors that are going on. Lifestyle is huge, stress is huge, sleep is huge, gut health is huge. So.
Right. I mean, the phrase you see a lot is subclinical hypothyroidism, right? Which maybe you can unpack that. What do people mean when they say subclinical?
Right. I try never to use this term subclinical because it means that, one, your TSH is a little off, and the range, as we say, a TSH between like 4 and 10. But your T4 and T3 are normal. The clinical part plays no part in the term subclinical hypothyroidism. It's just not a criteria. It's just a term we use where we say, all right, the TSH is off, but if you check those other levels, they're normal. That means that end of game, we just recheck it again in 6 months. But it doesn't take any account of how the person's feeling. So it's just a misnomer.
So, it strikes me that one of the ways that this can sort of confuse people is because these markers can vary a lot, because they intersect with a lot of symptoms that can be multifactorial, could have lots of different causes. Do you get a lot of folks coming to you saying, look, I have some fatigue, I feel a little off. We could squint and look at these markers and say if we
Right.
use subclinical, they're a little off. I just want to go on a little bit of hormone replacement therapy. Why shouldn't I just try that to see if it's going to help?
Now, there's nothing wrong with doing that. If we think, all right, well, maybe we could make this this T3 a little more optimized. There's nothing wrong in doing that. Especially if a physician's going to follow up and recheck levels and reevaluate symptoms. But that's where I would also say it might be this, but we need to check your adrenal axis. We need to know what's going on there, because sometimes that's the real issue. I just did an online masterclass where we had we included in a cortisol curve in all these patients that were considering they were having thyroid symptoms. All the cortisol curves were off. So if we don't fix the adrenal axis, you're never going to feel better just tweaking thyroid hormone up and down. Yeah. So
and is there a you mentioned it probably can't hurt as long as you're being guided, but what's the risk? What would you argue against somebody diving into the treatment plan of thyroid hormone replacement?
Yeah, you might have side effects. Side effects of too much thyroid hormone, especially if you don't need it, are palpitations, anxiety, sleep problems. You just might not feel better in general. You might might have some hair changes. So it's not a quick fix. So that's where I have the conversation. We can try it, but we need to look at other things too.
And is that a reason that you might start with sort of lifestyle things first and say how
Yes.
much of these symptoms that you're having, which could be caused by a lot of different things, can be addressed with some of these lifestyle changes before we go down the road of getting you on this
Exactly.
replacement?
Yeah, and I should mention the micronutrients are important too. So if we replace the micronutrients that may be absent, then the levels, if they level off, then that kind of takes the abnormality out of the picture as far as the thyroid hormone. So, yeah, I look at patient care as a team. I present all the options. We come up with a consensus what we want to do, but I try and give all of the options because I don't want to lead someone down the path that all your symptoms are thyroid when they aren't.
Right. And if I start on replacement hormone, can I get off of it at some point, or am I committing to a life of doing this?
That's a great question because actually we are successful in getting patients off of thyroid hormone replacement. Just because you're on thyroid hormone does not mean that this is what you're going to have for the rest of your life. As long as you have a thyroid and we're able to optimize your own thyroid function, you don't have to be on thyroid hormone replacement or less thyroid hormone anyway. So it's especially in the case of Hashimoto thyroiditis, because I use those thyroid antibodies as a guide to what's going on with the immune system. If we address what's going on with the immune system, it allows the thyroid time to work for itself a little bit, and then we can get patients on less. And some patients, depending upon how much they require to start with, none at all.
Interesting. So you can sort of regain normal thyroid function.
It all depends upon, going back to the ultrasound, if I see the antibodies go down, but it also depends upon what it looks like. So if it looks like, hey, this is, I hate to say, end of the spectrum, sort of, the chances are low.
Right.
But
so let's maybe end with what folks can do with maybe the preventative care side of this. What can they do to make sure they don't have to come see you?
Yeah.
Some of these things we talked about, autoimmune conditions, something like a Graves', maybe there's less you can do to kind of prevent that. But in terms of just keeping your thyroid healthy, we've been talking about a lot about lifestyle and micronutrients, but maybe dive into specifics. What lifestyle factors do you like folks to do, and what micronutrients are important to keep healthy levels of, to just make sure your thyroid is as good as it can be?
Great question. So in order to prevent coming to see me, so the goal is, it's from a lifestyle standpoint, sleep is so essential. We live in a 24-hour society where nobody shuts down, but try and get sleep. Sleep is essential. I mean, 7 to 9 hours of sleep is important. Stress management, because so cortisol curves should be highest first thing in the morning with a gradual decline towards the end of the day. And it shouldn't be high all day long. It shouldn't be low all day long, because that's going to impact thyroid function too. So if we can stay ahead of stress, again, that's a tough one. I mean, everybody's under stress, but trying to at least manage what you can, and don't make managing stress become stressful. That's tough too. Detoxification on a regular basis is so important, because we're exposed to countless chemicals on a regular basis between, the food we eat, the things we clean our house with, the things we clean ourselves with, medical products. We're exposed to endocrine disruptors all over the place. We can't get away from that. Again, don't let that be stressful, I always say to my patients. But if we can help our body handle it a little bit better, so detoxifying, getting antioxidants in on a regular basis. Selenium is a super important one to help protect your thyroid. Selenium is essential to not only help the thyroid work, but it protects the thyroid from inflammation. So making sure it's as easy as 2 Brazil nuts a day, getting selenium, a little bit of pumpkin seeds. That's all you need as far as selenium and the thyroid needs. So sweating every day helps us detoxify. It doesn't have to be a sauna. It doesn't have to be a 10-day detox or anything. Just simple things that help our body detoxify. Hydration is important. Trying to stay away from foods that are overprocessed. That's essential. I mean, trying to get whole organic foods as much as possible. Those are kind of the key things and that probably echoes a lot what you hear from other folks as far as hormones. So it's the more we keep our body in balance, the more we decrease inflammation. It kind of protects our thyroid now, preserves our health now, and when you're looking down the line, not needing to see an endocrinologist, but preserving our longevity and resilience as well.